but today's lecture is called Discovering the New Therapeutic Targets in Retinoblastoma. We're joined by Dr. William Harbour. He's a pioneering retina specialist, ocular oncologist, and cancer researcher whose discoveries have transformed the management of patients with uveal melanoma, retinoblastoma, and other eye cancers. Dr. Harbour graduated from Johns Hopkins Medical School and followed with a residency at Wills Eye Hospital. He did a retina fellowship at Bascom Palmer Eye Institute and his ocular oncology fellowship at UCSF. Then he started his postdoctoral training at WashU in St. Louis, where he continued as faculty. And today, Dr. Harbour is currently the chair of the Department of Ophthalmology at the University of Texas Southwestern Medical Center in Dallas, Texas. And so with that, I will turn it over to you, Dr. Harbour, and we thank you very much for being here today.
Thank you, Jay, and it's a real honor for me to be here and speak to you all today. I want to thank the Alex's Lemonade stand for funding our research, and it's a real pleasure to be here. Let me bring up my screen. Just want to confirm that you can see that okay?
Yes, we can.
Okay, great. As was mentioned, I'm an ophthalmologist and I specialize in ocular oncology. I've also run an NIH-funded laboratory for over 25 years, and my research has focused on sort of the connections between the genetics and genomics of retinoblastoma and uveal melanoma and clinical phenotype and how those connections can inform better management and therapy. These are my disclosures. None are relevant to the talk today. And as many of you will know, retinoblastoma is the most common eye cancer in children. It occurs in about 1 in 20,000 live births. It's more common in some countries than others. In countries with low socioeconomic situations, it seems to be more common for reasons we don't fully understand. It most commonly presents in developed countries as leukocoria or white pupil, as we see in this child, or crossed eyes or strabismus. And it usually presents before the age of 2, often before the age of 1. And I see many children that are diagnosed before the age of 6 months. In less developed countries, unfortunately, sometimes it presents as an orbital tumor, much more advanced and much more deadly. There are many efforts being made to improve the management of retinoblastoma around the world, earlier diagnosis and effective treatment. What I'm going to talk about today mostly applies to these children that we catch relatively early when it's not outside of the eye. And what's interesting when you see a small retinoblastoma, they are very circumscribed and very vascular. And if you look histologically, they're exquisitely oxygen dependent. So in the center here, we have a blood vessel, and surrounding the blood vessel is a cuff of viable retinoblastoma cells. And right at the edge, it's been approximated to be about 100 microns from the blood vessel. You have this abrupt cell death that occurs, a necrotic cell death. And this exquisite dependence on oxygen is very characteristic of retinoblastoma in the earlier stages. But what's interesting, as the tumor progresses in the eye, it transitions to the seeding phenotype, which we're showing here. And the vitreous has essentially zero oxygen tension, or very near it. And yet these seeds proliferate very rapidly and effectively and are not impaired really at all by the lack of oxygen. And it's this phenotype that is associated with increased chemoresistance, loss of the eye, in other words, failure for therapy to be effective. And then worse prognosis, more likely for optic nerve invasion, metastasis, et cetera. So there's some type of a transition that occurs in almost every retinoblastoma if they're allowed to progress long enough. And here's just a beautiful example of a patient who has all three stages. Here's an oxygen-dependent solid tumor, sort of up to the left. And then there's this sort of intermediate transition phase where it's starting to fluff up and get ready to seed into the vitreous. And then over here we have these seeds that are in the vitreous and are essentially oxygen dependent. And we'll come back to that in a little bit, but I want to turn just for a minute to talk about the clinical management of retinoblastoma. Traditionally, there have been a number of treatment options as listed here. Historically, the most common option is enucleation or removal of the eye, and that's still done in appropriate cases, depending on which country and how early children are typically detected. We still have to do enucleation. In my practice, is probably about 10% of cases. Up until about the mid-1990s, the alternative to enucleation was radiation, external beam radiation, and it's very effective at killing retinoblastoma. However, it's associated with a high rate of second primary tumors in the radiation field, which are often lethal. So external beam radiation has been essentially abandoned for other options, namely chemotherapy. The options at the top, laser, cryotherapy, and plaque radiotherapy, are really ancillary or supplemental treatments. They rarely can alone take care of retinoblastoma. So we don't do external beam anymore. Most of the treatment we do these days is chemotherapy, and it's been known for a long time that chemotherapy can cause retinoblastomas to regress. This goes back to the 1950s. But it was also very quickly observed that chemoresistance and tumor recurrence was almost universal. And so chemotherapy was sort of abandoned until the 1990s, when the concept was brought up again, initially with systemic intravenous infusion chemotherapy, with the idea that, well, let's shrink the tumor and then we can use laser and cryotherapy to kill it off before it grows back. And that approach, chemo reduction, as it became called, was the most common therapy up until say the late 2000s. And it's very effective in early stages, A, B, and C in particular. It requires typically 6 to 9 cycles of carboplatin, vincristine, and etoposide. It's generally well tolerated, although there are some side effects with these agents. And here's just an example of a patient with a very nice response. We consolidated that with laser therapy, and the patient did very well. The problem is, once you get into group D, that's where you start to see seeding. It doesn't work as well. It may be about 50% of patients with group D will have a reasonable response. And then those with E, where there's more advanced seeding, retinal detachment, et cetera, really don't respond to systemic intravenous chemotherapy. So the next phase in the evolution of chemotherapy treatment was intra-arterial chemotherapy, which was developed by the Japanese and then brought to the United States about 15 to 20 years ago, and has undergone further improvements and optimization. Typically, this is done by an endovascular neurosurgeon, and the agents that we use include melphalan, carboplatin, topotecan. Melphalan is by far the most effective, but is also quite toxic. So that's dose limiting. I personally try to avoid the melphalan when possible, combining the other two agents, but sometimes we do have to use the melphalan, and we see microvascular angiopathy and other toxicities that can occur from this. This is just an example of one of our cases where they've inserted the catheter in the femoral artery, and now they're placing it into the orifice of the ophthalmic artery. And then we see, as the fluoroscopy shows, the dye entering the eye, and then we infuse one, two, or all three of the drugs, depending on the situation. And here's just an example of a case that responded very nicely to intraarterial chemotherapy. In centers that do this commonly, the success rates are very good. The technique associated complications are quite low. In my center here at UT Southwestern and Children's Medical Center of Dallas, we use this in the majority of patients to start with. We are able to save many more eyes than we were in the past. But again, we're somewhat limited by the toxicity, especially of the melphalan. The other issue is with the seeding, which I had mentioned previously. The intraarterial chemotherapy does a much better job than intravenous chemotherapy against vitreous seeding and subretinal seeding, but not 100%. So more recently, the technique was developed to supplement intravenous or intraarterial chemotherapy with intravitreal chemotherapy. And for many, many years, it was considered very bad practice to introduce a needle into the eye of a child with retinoblastoma, typically for the reason of biopsy. So when I was in training, it was really more or less forbidden that you would insert a needle into the eye of a child that you thought might have retinoblastoma. So there was a real barrier to this concept of injecting chemotherapy into the eye. However, a technique was developed that has proven to be very safe. We use a very, very small gauge needle, 32 gauge needle typically, and we simultaneously apply cryo to the injection site, and I'll show you a short video how that works. And the agents we are using now are melphalan and topotecan, this has allowed us to save more eyes that we would have lost even with intraarterial chemotherapy alone due to persistent seeding. Again, the melphalan is the most effective, but causes toxicity. We can see really severe retinal damage, chorioretinal atrophy caused at the injection site of the melphalan. So again, we really try to avoid the melphalan whenever possible, but the topotecan is not as effective, but we're always balancing these issues, and we'll come back to that in the research part of the talk. This is just a video of how we do this technique. And again, we're going to inject and cryo simultaneously, and that seals the injection site, prevents anything from egressing from the eye, and it also freezes any cells that might be at the needle site. So this has been quite effective. Here's a child here who responded very well just to intravitreal chemotherapy. Our current challenges, as I've alluded to, are really, number one, with chemoresistance. We know there are a number of mechanisms that retinoblastoma cells use. They upregulate ABCB1, a peak glycoprotein. They upregulate epigenetic programs that we recently published in Cancers, a study where we looked at this and found that the PI3 kinase pathway, for example, is epigenetically upregulated. So it's a universal problem in retinoblastoma. And we also have these agents that are not specific, that they aren't based on any specific understanding of retinoblastoma, agents such as the alkylating agent melphalan, which is quite toxic. So we end up with these issues of therapeutic index and toxicity. With that in mind, my more recent research in this area is focused on trying to identify new therapeutic targets in retinoblastoma, starting at the genetic level. And as most of you will be aware, there's two types of retinoblastoma. There's the hereditary type and the non-hereditary type. Heritable retinoblastoma starts with a germline retinoblastoma mutation, which is passed in an autosomal dominant fashion. And then in the developing retina, the other allele becomes mutated. The likelihood of this approaches 100% in at least one developing retinal cell. So the penetrance is very high, somewhere around 95%, excluding these unusual low penetrance genotypes. The tumors tend to be multifocal, bilateral, increased risk of second cancers, and they tend to occur at an earlier age. The non-heritable form is where the child is unlucky enough to develop two mutations in the same developing retinal cell during the window of susceptibility. And in that case, the likelihood of that is so rare that it's always unilateral and unifocal. It's non-hereditary, of course, and they tend to occur at a later age. The problem is that the RB1 mutation, the type of mutation, et cetera, does not explain this phenotypic switch that we discussed earlier that we see during retinoblastoma evolution and progression. We a couple of years ago, quite a few years ago, started this work and published it last year in Science Advances. Started looking at the genomic landscape of retinoblastoma, both in cases that we had performed either whole exome or whole genome sequencing, as well as what was available in the public databases. And there were 103 cases of primary retinoblastoma that we looked at, and we used state-of-the-art analysis pipelines at the time, and we showed what you would expect, that majority of the tumors have biallelic mutations in RB1. There is this small group of patients that have been described. It's about 2 or 3% of retinoblastomas that don't have an RB1 mutation, but instead have amplification of NMYC. And then there are a few that have both. But besides that, there's kind of a smattering of mutations across a number of different genes. And then there are a whole lot of tumors where we don't really see any recurrent mutations. So it's a pauci mutational tumor. But if you do look at the recurrent mutations, the most common mutation other than RB1 itself is BCOR. And then there's this list of other mutations at decreasing frequency. Down at the bottom are the chromosome copy number gains and losses that are commonly seen. The most common is gain of 1Q, and the second most common is gain of 6P. So we'll come back to that in a little bit. But how do we get from there to a targetable molecular target? Well, I'm just blowing up the region here, showing some of the more common mutations. And if we do different types of analysis, this is a ingenuity pathway analysis to look for known protein interactions between the products of these various genes. a pattern arose here. First of all, we see here's RB1 itself, here's B-Core, here's NMIC, and then some of the other recurrent mutations here. And what we see is they all seem to point to this pathway, this estrogen receptor, estrogen-related receptor pathway. And so we looked at first at a large set of primary retinoblastoma tumors, not cell lines, at the expression using qPCR of the 2 estrogen receptors and the 3 estrogen-related receptors. And the only one that was really expressed at significant levels was ESRRG. And when we looked with single cell sequencing, we had 5 retinoblastoma samples at the time. The only one, again, that really showed significant expression was ESRRG. And what's interesting, of the 5 samples here, these were from enucleated eyes. 4 of these had never had treatment. They're treatment naive. But the one that had failed intraarterial chemo, I'm sorry, it was systemic chemo, but prior to enucleation, had the highest level of ESRRG, suggesting that perhaps ESRRG becomes upregulated with exposure to chemotherapy. So what is ESRRG? It's a member of this estrogen receptor related family. There's an alpha and a beta as well. ESRRG is located on chromosome 1q, this most commonly amplified region in retinoblastoma. It's widely expressed during development in the retina and the nervous system, and it's been shown in several neuronal models to orchestrate mitochondrial oxidative metabolism. So this is just from our data showing some of the eyes that we have that were enucleated have some areas of normal retina spared. So we were able to look in these areas. You can see the tumor cells here at the top where it says T. But in a normal retina, you see scattered expression of ESRRG, possibly transient. This is from a very young child, so there may have still been some ongoing retinal differentiation here. But it's sort of a scattered pattern in a small minority of retinal cells. Whereas if you look at a retinoblastoma tumor, you see this very, very diffuse expression of ESRG in the white here in this multi-IHC image. And in particular, if you look at the H&E, again, we see this pattern of viable cuff of retinoblastoma cells surrounding a blood vessel where we have the V here. And then after that, you have this abrupt transition to necrotic cells. And between this viable cuff and the necrotic cells, there's this sort of intermediate zone where cells are still alive, but they're on the verge of, they're very hypoxic. And as we can see from the HIF1 alpha, the regions just outside the cuff are extremely hypoxic. And those are the areas that are expressing the ESRRG. It's not uniformly expressed across the retinoblastoma cells. It seems to be increased in these hypoxic areas. Also of interest, it's uniformly highly expressed in the vitreous seeds. Here's just an example of one large seed where almost every cell is expressing ESRG at high levels. And interestingly, in a case with optic nerve invasion is the highest risk feature that we look for on histopathology for increased risk of metastasis. And the small number that we've been able to look at, the invading cells are highly expressing ESRRG. So this suggests that ESRRG may be playing a role in tumor progression, possibly being increasing as a selective pressure related to hypoxia. So we went and did further experiments in our low passage retinoblastoma cell lines. These are from our patients who had to undergo enucleation. And so these are relatively early passage cells. And we performed RNA-seq on 6 different lines, and we performed ChIP-seq on 2 of the lines. And we performed the RNA-seq before and after knockdown of ESRG. And then we compared the ChIP-seq data for ESRG with the RNA-seq. And what we find is that the genes that are regulated, both up and down regulated by ESRG, are highly enriched for genes involved in oxidative phosphorylation, response to hypoxia, as well as cell cycle and neurogenesis. If we look at what happens when we place these low passage retinoblastoma cell lines in hypoxia, meaning less than 1% oxygen, that hypoxia alone adversely affects survival. But if you then go further and knock down ESRG, you have almost complete loss of viable cells. Whereas in retinoblastoma cells in normoxia, the hypoxia has much less effect. So this data suggests that that ESRG is stimulated by hypoxia, and it's actually required by the retinoblastoma cells to survive in the presence of increasing hypoxia. Now, what was interesting is that we were looking at the protein sequence of ESRG, and it contains this motif that is very, very similar to the motif that E2Fs use to bind to RB. And in particular, this motif is present in ESR1, ESRRA, and ESRRG. But only in ESRRG is this motif in the DNA binding domain, suggesting that perhaps if RB were to bind here, it might actually prevent ESRRG from interacting with its promoters. And indeed, RB does interact directly with ESRG, as we show here through IP, both for RB and ESRG. For sake of time, I have taken out a number of other IPs and luciferase assays, et cetera, that are in the paper. But essentially what we showed is indeed RB binds to ESRG and prevents it from interacting with its promoters and prevents it from activating transcription. So sort of bringing this all together, loss of RB itself leads to increased ESRG expression or activity by the loss of this inhibition of ESRG. I also, for sake of time, skipped over the data showing that B-core itself inhibits ESRG, and that there's a interplay between RB, B-core, and ESRG, a negative feedback loop. So when you lose RB, this releases ESRG from this negative inhibition. The ESRG is further activated by hypoxia. We hypothesize creates a selective pressure to further increase ESRG in this increasingly hypoxic environment that the retinoblastoma cells find themselves in during this seeding phase and beyond. The ESRG allows the cells to survive in this extremely hypoxic state by altering oxidative mitochondrial oxidative metabolism. So loss of B core also augments ESRG activity, as does activation of CREB-BP, which was another mutation that that was on that oncoprint that I showed earlier. And then again, 1Q gain would further increase ESRG. So these lines of evidence suggest that ESRG may function as an oncogene during retinoblastoma progression, and that the retinoblastomas may develop a, if you will, oncogenic addiction to ESRG, suggesting that perhaps one could target ESRG therapeutically. And so we looked at this with an available ESRG inhibitor from GSK, and indeed, if you take, even normoxic cells, you will see some decrease in viability as you increase the concentration of this ESRG antagonist. But this effect is enhanced in the hypoxic state. And we showed this in 2 different of our low passage retinoblastoma cell lines. So summarizing this data, our current modes of delivering chemotherapy have really dramatically increased our ability to save lives, eyes, and vision. So we've dramatically improved since the time that I was in training. We're grateful to be where we are now and being able to manage these children. However, we still lose some eyes, either because the tumor is too advanced or because the tumor develops chemoresistance, or that the eye succumbs to toxicity from these non-specific therapeutic agents that have been around really for decades. New targeted therapies are desperately needed, ones that are less toxic to surrounding normal tissues. So we suggest that the recurrent mutations that we see in retinoblastoma, RB1 itself, as well as B-core, CREB-BP, 1Q gain, maybe others, may have in common the effect of increasing ESRG activity, and that these ESRG expressing cells are the ones that survive in this increasingly hypoxic zone between viability and death. And then this creates a selective pressure a survival pressure to continually express and increase the activity of ESRG. Thus, this possible oncogenic addiction to ESRG could make this a rational therapeutic target. You may have noticed that the doses, the concentrations of the GSK inhibitor that I showed are a bit higher than we would want in a clinical setting. And so this really points out the need for future studies to further address the potential of ESRG as a target for therapy, and to develop cleaner drugs that can be used at lower concentration. So I want to thank you for your attention, and I'm happy to answer any questions. Thank you.
Thank you very much, Dr. Harbour. Appreciate that talk. We have one question that's come in so far. If people have other questions, just click the Q&A button at the bottom of the page. You can easily submit questions there. The first question that came in is, does ESRG expression correlate with HRPF or disease outcome?
HRPF.
I'm not familiar with that.
Yeah, I'm not sure. We have not looked directly at that correlation between ESRG expression and disease outcome. In terms of progression-free survival, We have shown that it's associated with ocular poor prognostic features, seeding, optic nerve invasion, 1Q gain, et cetera. But in terms of direct correlation with progression-free survival, we have not shown that. And the reason is that, you know, in the United States, the rate of extraocular progression metastasis is fairly low. So you have to have a large number of patients and long follow-up to really have statistical power to look at that.
So the person responded and said that HRPF is high-risk pathological features.
Yeah. So thank you. That's what I was just saying, that yes, in the cases that we've been able to look at, it has correlated, you know, both with vitreous seeding and with optic nerve invasion.
Okay, another question. Would ESRG also serve as a diagnostic marker for screening early diagnosis of retinoblastoma, or would it be indicative of potential metastatic state of the tumor?
That's a good question. Diagnostically, I don't think so, because it's not specific to retinoblastoma. You can see it, as I showed, in normal retina and in other neuronal cell types, but it could potentially be a prognostic biomarker. And that's something we're interested in looking at. Could we measure this perhaps in the aqueous as a biomarker for a more advanced disease and possibly the presence of high-risk pathologic features. In terms of correlation with metastasis, I think that you know, it would be interesting to look at ESRG levels in CSF or other liquid biopsy settings, but to my knowledge, that has not been done.
The next question that came in is, can the ESRG activator inhibit retinoblastoma growth through P21 or P27, as has been reported in prostate cancers?
Well, that's very interesting. I cut that part out of the talk, but it is in our paper that shows that P21 is regulated by ESRG in retinoblastoma cells, as in prostate, and that there is this negative feedback loop. I apologize for kind of taking that out for sake of time, but yes, there might be a role for reactivating P21. However, in retinoblastoma, we're missing RB1 in most cases, so the P21 would not be able to function by hypophosphorylating RB and reactivating RB, although it may work through other mechanisms such as CDKs.
Okay. Next question, is ESRG targeting also effective in orthotopic xenograft models as a monotherapy or in combination with chemotherapy?
A great question. We haven't done that yet. You know, we published this just as I was moving from Bascom Palmer in Miami to become the chair here at UT Southwestern, and we plan to do the in vivo modeling and other work, but have not had a chance to do that at this point. That's a great question.
All right. Have you looked at targeting some of the other regulators of ESRG in combination to see if this improves outcome in vitro?
I have not, but would be interested to know what compounds might be the person may be thinking of. Okay.
We'll see if they respond. And then another one is, how complex is the intravitreal injection in terms of technical expertise needed? Would this be possible in a developing country with minimal resources to improve outcomes?
Yes, absolutely. Any ophthalmologist could be trained in a day to do this technique, and even a non-ophthalmologist, if they had some medical training, could be taught to do this. It takes a little bit of dexterity to be doing something with both hands at the same time, but it's very teachable and very much could be done in developing countries. In fact, That's one of the things that excites me about looking at new therapeutics, is that we do have this potential very low tech delivery system if we had more effective drugs.
Wow, that's incredible. It could be a game changer in some of these countries where
Yeah,
the outcomes
I
aren't
think,
as good as here.
right. It would need to be combined with something else, but it could definitely play an important role. It could be combined perhaps with intravenous chemotherapy, but yeah, it could definitely be done in those environments.